Good morning, everybody. My name is Lucy. I'm an arts producer in the CUH Arts team. And on behalf of CUH Arts, I really warmly welcome you to this session, our final webinar in a series of sessions which have been exploring dance within healthcare settings, specifically in acute settings. And welcome back if you've attended one of the 3 sessions which we've already been delivered. There's a few names popping up who've been in other sessions, so it's really wonderful to have you back. So to get started, hopefully some of you are familiar with CUH Arts already, but just to give a very, very brief overview, we're hosting this webinar series today. We are the Arts in Health programme, which runs from Cambridge University Hospitals. And we aim within our programme to humanise healthcare, inspire hope and promote wellbeing. And we do this through our cross-arts live and participatory programmes, through art commissions in both our current hospital spaces and looking ahead to 2 new hospitals that are being built on site, and through creative engagement out in the community. And on the screen is just an example of the kind of types of programmes that we deliver, both for patients, staff and their families as well. We can go to the next slide, Annie, that would be great. This year we've been celebrating 10 years of our Dance for Health programme, and on the screen you can see examples of an exhibition that we have currently on, which is called Conversations in Movement, and you'll be seeing some really beautiful imagery throughout Philippa's presentation from the artist Lena Yokiyama, who came and looked at our Dance for Health programme through a different medium, through live illustration. And there's some really beautiful imagery from the time that she spent on the Paediatrics wards with Philippa. So we have an exhibition celebrating the legacy of 10 years so far of our Dance for Health programme. We've also had a number of commissions this year, and we're really looking forward to having Club Origami Takeshi Matsumoto coming to our Paediatrics wards next week, and also looking forward to having Sanskruti back, who came and were part of our arts festival. They're a South Asian dance collective. I'm hoping that Krishna's here today. Actually, I saw her name pop up, and we're hoping that Sanskruti are going to come and spend some time on the paediatric wards later this year. So we've had a really busy year thinking about both celebrating and amplifying dance across our hospitals, as well as thinking about dissemination, of which these webinars are a really, really key part. This work has been happening quietly for 10 years. And the webinar series is this really, really, it is a wonderful show, isn't it, Club Origami? This webinar series is an opportunity really for us to share some of the practice. It's been happening quietly and becoming much more integrated across the hospitals at the hospital site. And we wanted to have an opportunity to really share our practice and initiate conversations with dance artists, clinical and research practitioners, and really think carefully and in conversation about the role of dance and movement in acute hospital care. And it's been wonderful, and it's lovely to end on a Friday with our final session, which is focusing on paediatrics. And I want to very, very briefly welcome our panel before we hand over to the presentations. So our first presentation today is going to be given by Lisa Dowler. Lisa is an independent dance artist, researcher, and the artistic director of Small Things Dance Collective. Since 2006, Lisa has worked collaboratively with Alder Hey Children's Hospital in Liverpool, working extensively with infants, children and young people on a range of mixed surgical wards, but extensively with neurorehabilitation and pre and post cardiac surgery. We're so delighted to have Lisa here to share her broad practice in hospitals, as well as her research into dance improvisation and the role it can play in clinical settings. We'll then have a presentation from Philippa, who's the lead dance artist at CUH. And she's going to be talking about her practice working across varied mixed surgery paediatric wards and oncology and haematology wards. Philippa will share our practice in paediatrics and the development of this work, which is very much integrated and delivered in collaboration with clinical staff and the play team at CUH. After the two presentations, Professor Bernie Cole will chair a further discussion with both Lisa and Philippa before we open up to questions. Bernie is a children's nurse who's worked clinically within children's surgery, neonatal intensive care, high dependency and intensive care settings in various hospitals across northwest England. And Bernie is currently working at Edgehill University with a research focus on improving children's management of pain, with an interest on how somatic dance practice can inform thinking and practice across healthcare. I'm going to stop talking there and hand over to Lisa for our first presentation, but just to warmly welcome our panel and thank you so much for being part of this session today.
Hello everyone, thank you so much for the invitation from CUH Arts, and really excited to have the opportunity to talk with Philippa. We've had lots of opportunity in the past to share practice, but not for a while, so that's really exciting, and thanks to Bernie for agreeing to chair the session. I can't see my presentation at the moment. There it is. Okay. So I've put a few slides together to keep me on track, really, because I've been working at Alderhay Children's Hospital in Liverpool as a dance artist in residence for 18 years now, and with Small Things Dance Collective. So it's quite a range of work that we do at Alderhay. So I'm going to give kind of broad brush across all of the different kinds of projects that we do. And then, if there's any questions or going into more specificities afterwards, I'm very happy to do that. So next slide, please, Annie. So just for those of you who are not familiar with Alderhay, Alderhay is one of Europe's biggest children's hospital, which treats more than 450,000 children and young people each year. It's one of the UK's 4 standalone paediatric trusts, and it's staffed with more than 4,000 employees. So just at the outset to say that even though Small Things is quite embedded in Alderhay, we don't reach everybody, and there's still a lot of staff and children who have no contact with the project. However, Alderhay has an amazing Arts for Health programme run by arts manager Vicky Charnock, who I think is here today. And so as well as dance, children have opportunities to engage in different kinds of art forms, including music, dance, animation, photography, visual arts, contemporary crafts, theatre and performance, cartoons and comics, creative writing and storytelling. And with Small Things, so just to name the other artists who I work with, so I initiated the project in 2006, and then I was joined by Kath Hawkins in 2007 until 2016. And then Sam Hickey and Louise Gibbons joined the project as artists, and they're still with the project now. And we also work extensively with 2 musicians. One is Georgina Asgod, who you can see in the background there with the cello. She's also a musician in residence at Alderhay, and has been there for a very long time, like me as well. And there's also Henry Horrell, who I think is going to come up on some other images. And then we collaborate also with Twin Vision quite a lot, who are a company also working at Alderhay independently and with us making films. So just to also kind of briefly touch on the practices that underpin our project as Small Things at Alderhay. So my background is in dance improvisation, and before I started in Alderhay in 2006, I'd been studying contact improvisation and performance practices of instant composition for probably about 10 years. So I was really kind of into these were my core practices. And then just around the time I started at Alderhay, I started a somatic training in body-mind centering. So I'm a somatic movement educator. So this work kind of layered in and on top of the dance improvisation practices I already had, and particularly the developmental movement patterns that are key to body-mind centering have really supported my work with children in the hospital. And then just to add, before we came to Alder Hey, Small Things Dance Collective was a performance collective, and our practice was really creating performance in environments. So outside of the theatre, outside the comfort of a studio, and working often in unused or derelict spaces to make performance and film. And so we were working very sensitively with sight, responding to sight and everything that was happening. And I think that this was a really important training in being able to work within a hospital setting where it's quite an unpredictable environment. It's not a kind of closed space when you go to work with a child. There's lots of things going on, lots of hustle and bustle, comings and goings. So to be able to work with my awareness and attention in this particular setting, these are the practices that have really underpinned that. So pretty much since the beginning, we've had two strands of the work that we've explored. So the first is the participatory work, which is most often one-to-one on a range of wards. But then we've also created performance which have ranged from kind of larger scale performances in public spaces in the hospital to more intimate bedside bespoke performances. And the units that we work on, like Lucy said, extensively we've worked on neuromedical with children with complex multiple disabilities, brain injuries, long-term vented patients. We work on the cardiac ward with children pre-surgery when they might be really anxious or needing to pass the time. They're nil by mouth, waiting to go down for surgery, and we come in and do sessions. And we also work with children post-surgery to help them manage their pain, to get them moving again, and to have a positive experience of being in hospital, to be able to express themselves creatively. And then we've also worked on renal dialysis for a while, and we've done some work on a mixed surgical unit, and occasionally we're drawn onto, we're referred to patients on high dependency units or intensive care, but less so than the other wards. And then we've also done a few projects over the year on the acute mental health unit as well. So next slide, please, Annie. So yeah, here's just some images to show the practice. So you have Sam and Louise on the right with a little girl. This was a little girl we worked with for a long time on neuromedical. So here we're working more somatically with touch, tuning in through touch, supporting her in her movement, rolling and exploring the movement that she had. The other images are on the cardiac unit. So we often work with babies on the cardiac unit who might have delayed movement after not being able to explore their movement as they usually would due to having had surgeries or having several lines in, not being held, having to stay in bed, not being able to roll around on the floor. So we can help and support them creatively through touch and play to explore their movement, and also generally just to have a nice time and to have a different kind of relationship with a professional in the hospital. And then you can see in the centre, there's a boy who has had open heart surgery. So we work a lot with children post-surgery who are presenting very similar to him. So you can see he's got a wound, an open wound, a wound from his surgery, but also these 3 chest drains, which are in place following surgery. And these are to drain the fluids. And it's really important for draining fluid that the child moves. But obviously, as you can see, they look really uncomfortable. And often children don't want to move. They don't feel comfortable. They're afraid of moving or they're in pain. So we find different ways of encouraging movement, more creative approaches to movement, which work really, really well. And next slide, please, Annie. And then there might be other sessions that look more recognisably dance. So you can see in the top right, you've got Sam and Louise dancing with ribbons. We've also got Mum joining in on that session. So yeah, this might be a session where someone is towards being discharged or also waiting to go for surgery. These sessions might look like this. On the left, there's a little girl, I think, with a neuro patient, and yeah, we're kind of exploring movement, reaching for bubbles, exploring movement in that way, and the little boy playing with objects at the bottom left. And then just on the bottom right, this was one of the projects that we did back when Louise and Sam started with us in 2016-17, working with the acute mental health unit. And we were able to take these children out onto the beach and explore environmental approaches to dance and their relationship to nature, which was really lovely. Next slide, please. So this kind of participatory work really fed into some of the research that we did. So we had lots of questions, going right back to the beginning of like, wow, what's going on? What's happening here? How are people responding? So the first study that we did, which I didn't publish till 2013, but we actually carried out the study in 2008 and 9, was on the neuromedical ward and the oncology ward, and it was a very open, qualitative study where we asked anyone who witnessed or participated in the sessions, in the one-to-one sessions, to respond, to describe their experience. So we asked the children, their parents, any clinical staff, play staff who happened to witness, be in the session, and also the artists to write from their perspective what they'd experienced in the session. And then this led into a mixed method study that we did in around 2013, where we collaborated with the Pain and Sedation Service. Because what had happened with the first study is that we found that a lot of children were asking for the dance artists when they were really anxious or in pain. So we were curious, are we actually having a positive impact on the experience of acute pain or the perception of acute pain for these children? So we did this study, and we were quite astounded by the response, that I think there was 96% had a reduction or a perceived reduction in their pain, with 80% having a greater than 50% reduction. And then in 2017, we created an app, which was really for parents and healthcare staff to be able to continue to explore the kinds of approaches we were using with the children after we'd left on the ward. So we often get asked, are you back tomorrow? Or can you come back tomorrow? And we're not around. So we'd often give parents ideas of things they could do. But this was an app which has, I think it had 4 relaxation videos in there, things that they could do to help support the children if they were in pain or really tired but couldn't rest. And then 4 videos, tutorials, which were ideas for creating movement, getting children moving again. Okay, next slide. And then this is just some images from the performance projects that we've done. So the one where we're in blue costume was called Taking Flight, and we created performance kind of structured improvisations. So performances that took place in the public spaces of the hospital and also the communal spaces on the ward. So the right top hand picture is actually on a ward, but it's a play deck at the end of the ward where all the children can come out. And we were kind of exploring the idea of migrating from the old hospital to the new hospital, inspired by birds. And then once we'd started performing on the wards, we were curious about developing that. So in 2018-19, we developed the Elation Project, where we performed, again, structured improvisations, but that were more participatory. There was more openings for the children to come in and dance, perform, play music with us. And we had, you can see this little girl's got a little red cape on. We had some red and blue capes made so the children could have a little costume and join us in the space of performing. And then this developed from kind of the more communal spaces on the wards to more intimately by the bedside. The next slide, please. So this on the left, I think we're on the renal dialysis unit, which is like a 4 or 5 bed unit. So we did a shared performance there. And then on the top right, you can see we're on oncology, and we're performing at the bedside for a little girl in bed. So we did a lot of kind of bespoke, responsive performances around the children's bedside. And I think the film for that is in the Padlet. If people want to watch, there's a 7-minute film around that project. And then just moving on to the bottom right, this was during the pandemic. So we were really lucky. Alder Hey were very keen to get the artists back in as quickly as possible following the first lockdown. And I think we were back in the hospital by the October 2020. But obviously there was a lot of conditions attached to that. So we had to be socially distanced. We needed to be 2 meters from the children, and obviously wearing scrubs and all the PPE, masks, glasses, gloves, etc. So our usual practice of working very intimately and with objects with the children, we weren't allowed to pass them anything. We weren't allowed to have any kind of contact. We had to work in a different way. So we were funded through ACE to develop Doorway Dancers project, where we created, we worked remotely as 5 artists to create these trios really. So there's a musician and a dancer. We were only allowed 2 people in the room with the child at once. And then I was actually projected. I didn't manage to get there live. I live in France, so I wasn't able to travel over, but I was projected onto the walls dancing as part of the trio. And you can see there I'm in the forest. I don't know if you can make that out from the picture, but I'm in the forest there. So we'd started to explore this idea of bringing nature into the clinical setting, and it felt really important at this moment when everything was more clinical than it had ever been, and also having a dancer projected on film on the bedroom walls was really nice, because I didn't have to have the PPE, so I didn't have a mask on. So obviously there was more human element of being able to see my face. So next slide, please. And then this project and the ideas kind of underpinning and bringing in nature into the hospital continued into our current project. So our current project, again, is funded by Arts Council England, and it's called Shifting Landscapes. We're in the 2nd year, maybe in the second part of the 2nd year already, actually. We're coming towards the end of that project. And then we also have 3 years of Children in Need funding, which will continue beyond the ACE funding. But so there's several strands of this project that we're doing at the moment. So the first one is obviously the ongoing ward-based practice, the one-to-one work that we've always done. That's always the core. So Sam and Louise are in pretty much every Tuesday, and I come back and do residencies every 4 to 6 weeks. I'll spend a week in the hospital. And then we also have a CPD strand. So we've been doing some artist development and training. So the picture at the right-hand side of the images was when Kai Thomas came and led some training for us in Liverpool last December, and he was leading alongside Paula Hampson, Pei Tong and Sarah Smith Sargent. So that was also CPD for us as Small Things artists. And then we've just finished, I think this week, with the last internship. So we've had 4 interns who've come in to shadow Small Things artists over the summer, and just finishing up now for just for afternoon sessions. And then we'll be auditioning soon. We've just had a call out, and we have two emerging artist posts coming up. So there'll be 10 full days, and they will be initially shadowing Small Things artists, then kind of sharing, leading, and then hopefully by the end of the 10 weeks, leading their own sessions in the hospital. And then we've had this Shifting Landscapes VR project that we've developed. So we, as a team, 3 dancers and 2 musicians, we were working on site creating films in nature. So one in a forest, you'll see the bottom right in the forest, and then the one to the left is the beach where we worked. And so yeah, these films are being edited for VR immersive experiences for children. And we tested them out earlier this year and launched the project in May. And this is a little girl who was one of our first to test it. And she said, it's better than Lapland. She was in the forest. She said, it's better than Lapland. And I feel like I'm not in hospital anymore. And she was one of those children. She was a cardiac patient. She'd been through lots of surgery. She'd been in hospital for a very long time. And so to hear her say, oh, I feel I'm not in hospital was such a relief to Mum. So she, and then we also had a couple tests on the neuromedical ward, and the little boy was like, oh, it's amazing, I think other children are going to like it. So we're looking at the moment the best way of using this technology, because for us, when the dance artists are in, we feel that we should be working in person with the children. So we're looking at different ways that we can use the technology across the different teams of the hospital. And then finally, we recently, through Vicky at Alderhay, we've been able to have a residency on the oncology unit in collaboration with the musicians. So the musicians have been already working up there for a long time, and we've been able to join them now. So working alongside the musicians every Tuesday morning and every Friday morning on oncology, which is just so far has been absolutely wonderful. So yeah, that's kind of what we've been doing for the last 18 years. And I'm very happy to answer any questions or develop any areas of that. But I thought it was good to give a range of the work. And, I've gone slightly over, sorry. I'm going to hand over to Philippa. Thank you very much.
Oh, thank you, Lisa. As you know, I have found your work completely inspiring for a long, long time. So in this Dance for Health programme here at Cambridge University Hospitals, the aim has been and continues to be to devise and deliver a participatory practice of dance. So Paediatrics, that's the most recent ward that I've been able to join. I've been there almost 2 years now and still feel very new to it and learning every day. Obviously, I'm always learning, but learning a lot. This is, the images are coming from a residency that was set up by our fantastic arts producer, Alice Woodhouse, who brought together the artist Lena Yokoyama, who is a dancer herself and has an arts practice of drawing. Alice managed to bring us together onto the wards. Lena and I moved through the different wards that I work on, but we spent a lot of time working on the pediatric ward because, as you can imagine, it's not always easy to go in and take pictures of young children, of families in distress, of managing that. Watching your images, Lisa, it brings such a palpable sense of what it's like in these spaces. With Lena was able to bring all her arts materials onto the floor, sit on the floor like a lovely big child and draw and interact. And it was so celebratory and fun. And Alice has then curated a beautiful exhibition that is now presently in our concourse at the hospital here, where Lena's work is being shown across the boards. So that's the background of the images that you're seeing. So Paediatrics, a place of a lot of emotionality, These are spaces where children are extremely ill. On the oncology pediatric ward, children are in rooms with their families, sometimes for a long time, 6 weeks, sometimes on some of the other wards, children's wards, more briefly, they come in, they're here for operations, treatment, they stay overnight or they stay for a long time. Everybody is hugely skilled, the medical team, in giving these children the most thorough and best experience they could possibly have in very challenging circumstances. It feels such a privilege every time I go onto the pediatric wards. We're looking at a continuum of needs. We're looking at engaging with physicality, with expression. Sometimes it's simply relieving boredom, anxiety, a lot of work around shifting the pain, supporting rest, alleviating anxiety. Much of this work that I'm doing is about engaging with the children and their parents. So I don't know if, Lisa, you have that same experience, but I'm often not just working with one solitary child. I'm working with a parent. Sometimes a whole family is in a small room. And it's like I'm stepping into a world in this small space. You go into these rooms, sometimes they're barriered, which means the child can't leave for up to 6 weeks because they're receiving very fragile, delicate treatments. They need to be very careful with infection control. You step into these worlds, and from the start, something that Lisa mentioned, the quality of attention you bring into this room that you are working in. We often talk about this improvisational work being bringing a theater space, a studio space. You step into these rooms and you're noticing, are there toys? Are there cards on the walls? How is the mother? How is the father? What's the level of tension? How is the child? How are they receiving the staff that come in? Is there fear, the need to hide, high anxiety when treatment, taking bloods, having your pump changed? How are children reacting to all of these interventions? Or is it a space that just seems to be bouncing with joy and energy? The image that you're seeing at the moment is a young lad. He was about 2 years old and very, very physical. He was pretty much literally bouncing off the walls. His mother was both very thankful that the treatment he was getting, but also very anxious about his level of physicality. In truth, when I was working with him, he was a dinosaur and I had to become a dinosaur. And we had to often just roar at each other. He needed to roar. And you can see he's in this group session that Lena captured, he's climbing up onto my body. He was so strong. He wanted to fly. He wanted to take off. No sense of pain, no sense of anxiety, thanks, Annie, around his physical ability. He wanted so much physical touch. And I think for his mother, it was such a relief to see that that was okay, that was acceptable, that he was acceptable, that not only was it acceptable, but I could work with it. I was getting enjoyment from it. I was very sore afterwards physically, but that shared excitement and joy brought back to her the sense of her little boy that obviously she loved and adored as he was. Thanks, Annie, for that. So often when you're stepping into these spaces, you're just gauging what's needed. There's a lot of play in this work. Children are naturally folding themselves into play at almost every moment. They are so alert to the possibility of what could happen. And we are comfortably in the realm of the nonverbal world. So when I come into a space, sometimes I come in and I say my name. That might feel too much, too alert, too much. So I will perhaps step back and I'll just play with the curtain and just let a hand come out and just give a little waggle. listen out for a response. Is that working? There's so many ways to enter these spaces that I think as dance practitioners naturally inhabit and embody the ability to be adaptable, to be flexible, to be bringing full attention to this space. Before I come to this slide, Annie, but we can stay there for a little bit. One of the big issues on the paediatric wards is around pain and physicality. So you can imagine that when your child is receiving a lot of very challenging interventions, their bodies are being cut open, they are being pumped full of medicine. There is often a fear of movement. There is often the need to swaddle your child, carry them, keep them close to your bodies. And for the physiotherapy team on these wards, this can often be very challenging. Lisa, you mentioned the child and the drainage of fluids on the chest. So these children need to move. Naturally, developmentally, they need to move, but there's often a lot of fear and protection around moving. So that's one of the big things that we need to contend with, persuading the children and their parents, their family, that it's okay to move, that we don't need to move big movements like the dinosaur boy that you just saw, but little movements, the whole work around fascial rehydration, tensegrity, that a little bit of movement will bring positive outcomes. So that's a big part of this work. I'm going to go back to telling a story. This is around a child who I met. I'm going to call him John. And if you don't mind, I'm going to just read out the blog that I wrote about it, because I don't want to miss anything. There's an anxiety around getting this work as well represented in these webinars as possible. So this is a story about John and his mum. It starts with a quote from his mum, who you can see far left corner. I didn't know how happy we were before. After a couple of weeks working together on C2, the mum said this to me, carefully light in her tone of voice. Her 7-year-old son had from the start greeted me instantly with his wide and enthusiastic curiosity. Although he didn't have many toys or stuffed animal in his room, each object he engaged with had his utmost attention. Fiercely intelligent and creative, he could turn a cardboard tube into a rocket ship and get you to see it as such and know it as such. His eyes lit up when I told him I was the music and movement lady, as did his mum. Ah, this is great, she said. We love music, so we wasted no time. The bed was cleared. He clasped the speaker, delighted that he got to control the volume, and the first Imagine Dragons song came on. At first, he was startled that he did really get to control the music, and it was loud, and I did really actually dance, and more than that, I also really loved his favourite songs. So his mum and I danced, waving our arms about in the small room, grinning at the sheer pleasure of witnessing his delight. After one song's worth of carefully watching us join in, he requested another Imagine Dragons song. And then he began to slowly allow himself to sink into the powerful harmonies, the words, his eyes closed, first his head, and then the whole of his body rocking out the rhythm. His mum and I, we watched him retreat, not far, but retreat into rich physical pleasure, taking himself to where he needed to be. My patience is waning. Is this entertaining? I've got this feeling, where I'm losing all control because there's magic in my bones. This song, Bones, was one he requested again and again and again. It would start our sessions off together. Song over, he would open his eyes, shining from the experience of feeling good. And the next song would be requested. So they were in the hospital for 6 weeks. Because of his treatment, he was not allowed to leave the room. This really was his world for the duration. I watched over the 6 weeks, his body respond to the medication, become fundamentally challenged. But every time we found a way to do something that felt significant. Even on his most tired weeks, when finishing had to happen quite soon after beginning, we were able to find the place and position where he found delight in shaping the experience, adjusting the volume, taking pictures of his mum and I dancing, pausing and stopping the music. His grin would widen. You could see it moving through him, nourishing him. Her light positivity and unswerving determination to maintain a modicum of happiness was before the only time was intrigued and impressed me the way she managed it. Her comment on her understanding of what happiness was before was the only time I witnessed the immense strain that she was managing. So one of the things that the physiotherapy team requested was that we try and pilot a disco session. Most of the sessions that I do are one-to-one in private rooms. They have really been struggling with the inability to get the children moving and doing the kind of physical rehabilitation they need. So we set up a disco session. I think it was called Disco Tuesdays or something like this. I can't remember. Something better than that. And the idea was to bring a disco ball into the space, dim the lights, and invite all the children to come out of their spaces, doorway dancing, funnily enough, Lisa, it was called, if they were barred and couldn't come out. And the idea was to invite all the staff, all the parents, all the children to engage. And it worked. It was delightful. Physios would turn up from all around the hospital to join in. Children would come out in their wheelchairs. One young child decided to become the DJ. He was paraplegic, couldn't move at all, but he had a wonderful sense of humor and played songs like I'm Still Standing. You know that one. And it was really often about the children watching their parents engage, the children watching the staff engage. And in this kind of a dance world, a movement that initially feels impossible, like this little girl was not able to raise her arms. This is something the physios were working on, her ability to spontaneously lift both hands up with the music. Boom, she took her hands up. I, of course, immediately mirrored and joined in, was told to join. There she is. She did it again and again and again. And of course, all the staff then are instantly mirroring, validating, honoring her achievement in that moment. It became such a favorite thing to do. I think one of the things that I could talk about is the way that you need to adapt the range, the depth, the broad spectrum of what a dance interaction looks like. So there's one space next to the school, because there's a school on these wards for the children who are there for a long time, which is more public. And there was a tiny little toddler, tiny little fragile girl who looked like she could just be blown away, and a huge dad, very tall man. He was kind of like a surfer dude. And when I said, here I am doing the music and movement, what would you like to listen to? He started off by requesting very gentle, very peaceful songs. And she sort of sat there, not really that taken by it, not really that interested. And I said to him, well, what kind of music do you like? What would you dance to at home? And he said, Thunderstruck. I don't know if any of you know Thunderstruck, but it's heavy rock. It's quite insane. And I said, okay, well, let's put that on. If that's what she knows you to be a dancer to, let's put that on. And we put that song on. Oops, that's my timer. We put that song on, and you could just see his body really wanting to go for it. But he was still crouched down, sort of in this sort of sheltered kind of harbor for his little girl. And I said, no, just stand up, take it, go for it, go for the music, let rip. So he did. This beautiful, tall, young beach surfer dad stood up, his blonde hair out, and he just danced. At which point, his little girl joined in. She stood up, she joined in, she beamed, she was recognizing her father in that moment. And of course, that music, I don't know, maybe have a listen to it afterwards, but staff were coming in, other children started to join, it became incredibly joyous. I think my time has also run out. I know it's really important that we give time for Q&A and for Bernie to guide us with her wisdom.
Okay, so thank you to Philippa and to Lisa for two really beautiful presentations. Been making notes, listening to them, and although I've heard about their work before and I know Lisa's quite well, the diversity of the way that they engage, the compassion that they bring to their work, the innovation and inspiration that they bring to children and families and staff, and the connection and the engagement and the sense of joy that they can bring to children and staff. It's such incredible work and so needed. When we met earlier, thinking about how we might frame this session, we came up with some questions. So I'm going to start to ask Lisa and Philippa these. My background is children's pain, so that's kind of like my fundamental connection to their work in some ways. So children experiencing acute or long-term pain have been shown to benefit from dance and movement practice. Typically within acute pain management in acute health settings like the hospital, outcomes of interest are focused on measurable outcomes such as reduction in pain intensity, reduction in medication requirements, quite narrow outcomes. So whilst appreciating that every interaction that you have with the children that you're involved in is unique and is a partnership that's dynamic and responsive to the moment, what sort of outcomes, if any, are you anticipating or working towards? I don't mind who goes first. Lisa's smiling the most at the moment. I'll ask Lisa.
Smiling at Philippa and saying, go on.
I can smiling. Yeah.
I can go. I mean, yeah.
Go
okay.
ahead. Yeah.
No, it's a really interesting question because obviously as an improviser, generally you're kind of working with the unknown. So you're not really intending to work towards any particular outcome or goal. And also kind of the frame of Arts for Health at Alder Hey is really arts for art's sake. So we're not forced in any way to be evaluated against clinical outcomes, but by doing the work you do reach some of the, like you say, the acute, which is why we ended up measuring pain, because we knew that we could kind of tick that box because we'd seen it happen over and over again. So I would say that I kind of go in with a kind of very broad, although I might know, obviously I know the condition of the child, I know why they're in hospital, I know what's going on with them, and I know if they're experiencing pain or not. I really go in with the broadest sense, the widest perception of the whole person and what is presenting. So even though I might be aware that there's pain as part of that experience, I'm working with the full experience of the child in hospital. And I think that's kind of in a way, that's the magical part of this practice, that by working with the whole person, somehow their perception and of their situation or their subjective experience in that moment shifts. So I do think also there is, if we work with touch, you're reducing tension in the body, you're reducing spasticity. I work a lot with children, with disabled children, and you know that for yourself, that when someone puts their hands on you and you're tense, it kind of eases your pain. So there is that physical sensation of pain that we can reduce in that way. But I think also just the kind of opening up their perception and their awareness of their body. So they're not zooming in on the site where the pain is, but they're becoming aware of their feet as well, or what's out the window, or, so it's just kind of broadening. So the pain might still be there, but it seems to be smaller in relation to everything else. And that seemed to be, and there's one example when we did the study that was really interesting, that we were on, the study was actually on orthopedics as well as cardiac and neuro. And there was one girl, she had spinal surgery, and she was scoring herself as a 10 in pain, which is like the highest pain she could experience. She was full of tears. she couldn't sleep. She was totally like a sympathetic nervous system state of like very alert, couldn't rest. And we worked with touch with her, and she fell asleep. So we kind of tiptoed out of the room, said to Mum, it's fine, whatever. Carried on working on the wards. And towards the end, about an hour later, she'd woke up and she said, I've got no pain at all. It was like, wow, what just happened? So I think also it's not that we kind of, fixed the pain in a way, but we provided the conditions for her to be able to do that for herself. So in body mind centering, we talk about the person as being the expert in their own body, and somehow we kind of enabled her to find a place to rest, to recuperate, for her body to somehow recalibrate or do whatever it did. But when she woke up, she said she couldn't feel any pain. So yeah, there's a lot going on. But I think that when we work with the child, we try not to focus in on the pathology, but with the whole, and that seems to be the magic of the practice in a way. By trying not to encourage them to move, they move, whereas if you say lift your arm up, like you said, Philippa, you're trying to get us to lift her arms up, but as soon as the music comes on, it's like it just happens. So it's something that seems to be, for me, where the magic lies with the practice. Yeah.
I asked the question because it's slightly provocative, because I'm both interested in those kind of like objective measures and not interested as a person. But certainly the world that you're navigating within an acute hospital setting, sometimes practitioners such as yourselves have to justify what you're doing and why it's worth having you environment. And it may not just relate to pain, Philippa, you may feel that, what sort of outcomes do you see that you get that actually can be communicated in a language that makes sense to the more, the healthcare staff, the more traditionally oriented staff?
Yeah, I mean, it's a fantastic question, because it brings up, first of all, pain is a subjective experience, and it's a cultural experience as well. It depends how you've been brought up to think about pain. I see some families who manage pain in a very holistic way, and that child seems to actually experience less pain. And some families who are very, very, their own inherited understanding of pain is so extreme that actually they are creating a very difficult environment for their child to experience the pain that they are feeling. But on the pediatric wards, I'm working with the play team. So they're my immediate colleagues, and their work is already so much more of what you were talking about, Lisa, holistic. It understands the wider perspective of treating a child. You're not just treating a medical, situation. It's a whole person you're talking about and a whole family that you're talking about. So they will often, I start with them. They will say, could you go and see so-and-so? They're very anxious. Could you go and see so-and-so? They're not really able to rest, or so-and-so is not able to move. So I have a little map already in my mind, and I have a sense of what would benefit the child, the family, the ward, the environment, because we're all working to the same thing, which is that the medicine is integrated, it works, and the child can go back home. So when I go into those spaces, I have a little bit of knowledge of what the outcome would like to be, what we want. But then you meet the child, you meet the room, you meet the person, and you begin to understand their version of their story. And what might have been an outcome, which would have been, let's get off that bed and move, actually becomes the child, for the first time, falls asleep deeply. And the rest that brings, and that sense of relief for the parent who's been watching a fretful child for maybe 24 hours, a child not being able to fully relax into their own body. I have a lovely pain story as well. It's my favorite because this child was so fantastic. This is the Elton John child who couldn't move his legs at all. And I said to the mother, has anybody ever talked to you about the benefits of touch and bringing touch to bone, specifically marrow? And she said, no. not somebody who would normally take herself to a dance class or anything holistic at all. She was proper challenging and skeptical. And I said, well, if you just bring your hands very gently and really listen in to the bone marrows and just very slowly. I was there for maybe 30 minutes, just moving down one leg and then the other, whilst he fell asleep. The room got quieter and quieter. He fell asleep. I left. Similarly, Lisa, I left. I said, I'll come back later. Went off to do other children, other sessions, came back, and she said, he is pain-free. Went back the following week, and she said, I've started doing it, and he doesn't struggle anymore with that leg pain. So fascinating. So the play workers are certainly paying attention to what's going on. So there is a huge bank, a huge library of how this work has worked. What we haven't done is gone in and investigate which cellular, brain, body, mind aspect has caused that complete shift. But what a difference it makes. What a difference it makes. Yeah.
I guess there'll be many people listening to this that are going, I wish I could make this happen in my hospital, or I wish I could make it happen, more quickly or more effectively. And I know some of the connections that you've had have been serendipitous from having spoken to you before. But beyond being persistent, how, have you got strategies that you think are effective in opening doors to people, staff, people in the hospital, as well as parents, and maybe children sometimes, as being skeptical about kind of like letting you in and make the magic that you create work?
You absolutely do need to find the people on the ward who understand your work. That's been my experience across all the wards. So I think in the paediatric wards, had I gone in through the nurses, it wouldn't have been received as well. The fact that I went in through the play team workers whose job it often is to manage those in-between spaces of a child very distressed before they go into an operation, or a child waking up post-operation. So engaging with those more liminal times in the child's hospital experience, they really understood and supported, welcomed the work and me. So when I arrive on the ward, they welcome me. They sit me down, ask me how I am. We have a conversation. They really support this work. So I think you do need to find your alliances within the ward to start off with. And then there's a lightness to this work that we bring. It's not heavy or demanding. It's showing that by working in this way, you're supporting the whole ward and patients. That part of an answer to your question. It's a fantastic question, Bernie, and very important. Lisa, do you want to add to that before I think of something else to say?
Got a few minutes left.
Yeah, I mean, I don't want to repeat what you said, but again, we've gone in through the play team and they've been like the greatest. And then like over the years, there's been different individuals. So obviously the pain team, which I think I met because of you, Bernie, but like once we'd started working with the pain team, now they do referrals to us, so they're kind of a great alliance for us in the hospital. And originally, again, like for me, the physios at the beginning, it was quite a difficult relationship, but we started making better relationships with different physios. So I think it really depends on the person. So I think it could be a different team in a different hospital, like you say, like maybe not the nurses on your ward, but maybe in a different hospital, those nurses are really up for it. But it is making those connections. Like I was very lucky to be invited to do some group sessions right back at the beginning. And then it was kind of by accident that the lead play specialist who happened to be on neuro said, this would be great on my ward, will you come to my ward? So it kind of just evolved like that. But I think it could take lots of different directions. But I think you do just need to meet that one advocate. But obviously most hospitals now do have an arts for health team, some kind of team or manager or coordinator. So they would definitely be the first port of call if I was knocking on doors now. and then if paediatrics, definitely the play team. Although I know Lucinda in adult care, she's gone in through the physios, hasn't she? So it does mean, yeah. And also, that was like it takes time.
It takes time. I mean, I started by saying this is new. It's 2 years. It is the beginning of this work. But having Alice Woodhouse, who commissioned the work with Lena Yokoyama and has curated this wonderful exhibition, as you say, having the arts team, it makes the work visible. Visibility is really essential, and advocacy is really essential. And the physios who wanted the disco session all love dancing. I mean, they were so inspiring just watching them dance. So the joy they brought to it. So that was a really wonderful moment. Not all physios love dancing. So yeah.
Like you say, documenting as well. We've always tried to document as much as possible that we can, because I think it is, and I know the play team has said this, it's a very visual practice. So it's actually quite hard for them to describe they're going to come and do this. And actually, just briefly, at the end of the pandemic, when we were trying to get back into working with touch, during the pandemic, we have this body ball thing that we do. So we're not working with touch, there's a ball in between. And Vicky sent the body ball video off the app to the infection control team, because trying to explain they're going to roll the ball. And actually they saw the ball and they were like, okay, they can work with the ball. And then, we worked with the ball for a few months. Then eventually we could come back to working with touch. But if we didn't have that visual reference, it's very hard to imagine what it might look like.
What sort of benefits do you think your practice brings to parents and caregivers? We've seen some of that through the pictures. The mother with the ribbon, and then the mother with the little boy that you were talking about. There's definitely that.
I mean, it's huge, and it's so there's such a continuum. So one of the stories I wanted to share was a lady who didn't have English as her first language. Her little boy, probably 13 months old, very, very ill. And I was able to go into the room, communicate that I was going to be doing music, and my hands probably indicating some sense of movement. But what we ended up doing is I just played some very, very, very gentle music, and I watched this beautiful young mother. She had the most amazing body, round and rounded, and she just rounded around her little boy, her beautiful hands. I really wished I was an artist and could paint it. And she just let her hands really hold this little baby, and started rocking her body, which was really interesting, Lisa. She started self-regulating. And as she started to do that, I found myself very gently mirroring it. I don't often use that as a deliberate technique, but it just felt right that we were all, as if we were all on an ocean together. This music was just taking us into this oceanic place. And this tiny baby just sort of completely melted into her hands, and he fell asleep. She was like this archetypal, kind of almost like a mountain, like a shield, just absolutely wrapped around him. She got quieter and quieter and quieter, and that was the session, So absolutely helping some of these parents and caretakers shift some of their emotional pain, their projected pain, giving them an opportunity to see their child well, to see their child beaming, thriving, joyous, creative, spontaneously sparking, laughing, and re-engaging. I think the tiniest little movement that shows that unfurling brings such a relief to a parent and lets them know that things can get better, and things will get better, and things can shift.
Yeah. Thank you.
Yeah. When we did the first study, what was really interesting, from the observations or experiences from the parents, is the main thing that came through was just the pure sense of relief from seeing their children having fun and smiling, and they'd be like, oh, you've brought Sienna back, or you've brought, you know, it's like, oh, I feel like I've got them back. And that is like the kind of the main thing that they feel is like this huge sigh of relief, like, oh, they're still here kind of thing. And then also sometimes, because on the neuro ward, some of the children in there for years, so it's like really, really long term. So the parents can get to know us and know that the session's going to be something positive for the child, so they can take a bit of respite. So sometimes they'll say, oh, can I go and have a fag, or can I go and get a coffee, or make a phone call, or whatever. So that feels lovely to me, that they trust that their child's going to be perfectly happy without them, and they can go and leave them. So we have this kind of respite thing. And then we've done a lot, like you said, Felipe, with the touch and showing, like there's a lot of kind of educational side of it. So I work sometimes with babies with delayed movement because they've had operations, not because it's a neurodevelopmental issue, but and especially with first time parents, so the lines all come out, they're able to touch them, but they're absolutely terrified. The child's like 5 months old, they've hardly picked them up, they've never. And then so yeah, just how to touch, how to hold. And actually last week I was in Alderhay, and there's a baby we've worked with for about, I don't know, he's 10 months. I think he's been on cardiac pretty much through that whole time. But he's had all his lines out. It's the first time I've seen him without everything. He's kind of, you know, he still can't sit up. But I came in and Mum said, oh, can I take a shower? So she had the respite moment. I was in the bathroom about half an hour. I was kind of waiting for her to come out because I was going to move on. Then she went, oh, now you teach me how to like sit with him and play with him. And so we had this like really extended session where I kind of showed her ways of how she could support him over a leg so he could have some tummy time. I don't think he's ever been encouraged to lie on his tummy. He's 10 months old. He can't roll properly yet. You know, or he'll roll to his side but can't roll over. So she kind of took both, you know, it's like you can do that and she can do that, which is lovely that she just felt like able to so there's, and that, I think that was kind of the idea behind the app as well, that they could have little educational things that they could do, ways of working with touch, like you say, Felipe, that's very simple, listening touch, that you don't have to necessarily go away and study for years to learn how to do, but has such a profound impact, you know. Yeah, kind of all of